I basically put this talk together to talk about some new approaches to managing patients who are hemodynamically unstable. Maybe not new approaches, it's more new sort of thinking in terms of how we assess and evaluate patients who are hemodynamically unstable. And I've kind of repurposed this talk a few times now, so I thought that it's probably best to use a case scenario. Let me just see if that goes. Yeah, to just introduce the concepts. And this was actually a case that I was involved with while on call in the unit a while back. So it's also just to maybe give you some food for thought while I go through the rest of the presentation. So it's a 55-year-old male, came to us after having a huge liver resection for cholangioCA on the background of hypertension, diabetes, and I think quite a markedly elevated BMI, but had quite a sort of a long prehab period before surgery and optimization nutritionally and in terms of their baseline sort of effort tolerance. Had previous cholangitis as part of their sort of previous medical history. So the patient had an epidural, A-line, CVP, general anesthesia, major blood loss, lots of resus fluid, was extubated at the end of surgery. Because the hemodynamics was such a problem, the anesthetist couldn't use the epidural intraoperatively, and the patient arrived in ICU on a noradrenaline infusion. And these are just some of the sort of parameters that that I thought would be relevant in terms of the patient's sort of immediate assessment on arrival in ICU. So lactate was 4, tachycardic, oliguric, and HB was 10. So what do we do next? And what your thoughts, what direction your thoughts sort of veer into, but I'll leave that with you for the moment, and I'll carry on with the presentation, and we can always come back to the case. And I'm conscious of time, so hopefully we're going to get through this before 3. So this is a fairly old sort of publication, but really it sums up how we assess patients who are hemodynamically unstable or needing some form of hemodynamic optimization. And we always need to assess whether patients are compensating for their shock, because we always, I think it's important to emphasize that hypotension, low blood pressure is a late sign of shock. We need to recognize shock before the blood pressure drops, because then it becomes very obvious. We obviously need to assess whether, this is a fluid responsive type of shock, or whether fluid administration is going to improve hemodynamics. And that's something that I'm sure we all sort of fairly comfortable with doing, or let's just say we quite comfortable assessing that, and we're quite liberal with giving fluids generally. And then an important question in terms of the type of shock, but also in terms of how well it's being compensated for, is to assess the vascular tone. And that isn't something that we need a special monitor for, but generally we can assess patients' peripheries, we can assess whether they're warm, whether they have a vasodilated, sort of bounding hyperdynamic circulation. Alternatively, we might be able to use some invasive monitoring that can help us determine what this patient's arterial tone is. And then probably what this talk is focused on is really what we should look at more closely when we're assessing patients, and that is what's called the mean systemic filling pressure. And that's a concept that has been around for a long time. It's nothing new. it was described by Arthur Guyton, and Guyton did his experiments in anesthetized or unanesthetized dogs and assessed this pressure, which he described as the circulating filling pressure in the venous system, and really assessed what that pressure is in relation to the pressure at the right atrium. And this is an important concept. So how he did it was he anesthetized dogs. He basically arrested their hearts and then measured the pressure once we had no flow in the circulation in the venous capacitance vessels. Now, why the venous pressure? Well, when we look at our distribution of blood volume, only about 30% of your blood volume is in your arterial circulation. Most of the blood that we store, let's just say that we have stored in our blood vessels, are in the venous circulatory or the venous compartment. So 70% of our blood volume is in the venous compartment. And that's certainly where a lot of the, let's say, the venous return is from, and what determines really the filling pressures, particularly across the right ventricle. And what Guyton illustrated was very important, and I'm going to move on to the next slide, because he essentially constructed what's called these venous return curves. And when he looked at the relationship between stroke volume and venous return, what he realized was that, first of all, the most important determinant of stroke volume is venous return. Okay, that was one of the things that he emphasized, and what we need to almost come to terms with. But more importantly was that as our right atrial pressure increases, okay, we see that on the x-axis here, so our venous return decreases. And what that means is that when we think about venous return, it's really this pressure, and I'll go to the previous slide, this mean systemic filling pressure, the pressure in your venous capacitance vessels that drives blood flow back to the right atrium. And the only way that that venous return is optimized is if we either increase the mean systemic filling pressure, and that we can achieve often by giving fluids. That's why fluids help the circulation or help the hemodynamics, is because we're increasing that venous pressure in your venous capacitance vessels. Or alternatively, we drop the right atrial pressure. And by those two mechanisms, we promote blood flow back to the right atrium, right ventricle, and therefore improve stroke volume across to the left side. And if we superimpose that on what we call the cardiac output or cardiac performance curves, what he constructed and illustrated was that for every patient, and I think this might apply to different or every patient's specific shock state, there is an optimal mean systemic filling pressure that drives blood flow back to the right atrium, that produces the best venous return and consequently the best stroke volume or cardiac output. So that's the first concept that I want to illustrate. And I think the next few slides really just highlight how we focused, or most of us were brought up learning and being guided by Starling's experiments. And this is actually Starling's experiment that I've illustrated here on the slide, where he isolated the heart and he kind of measured this stroke volume or venous return preload, he called it, into the right ventricle. And as you increase preload, you increase stroke volume. But really, what he illustrated was that all we're doing was we increasing venous return. And at some point, when your Starling curve starts to flatten, that was really the point where your mean systemic filling pressure and your right atrial pressure equalized, so you had no further increase in flow back to the right atrium. That's essentially what Starling showed. And really, when one looks at Starling's original experiments, he got the axes the wrong way around, because on the left here, where my arrow is, that's where that's the data that Starling illustrated, and he put cardiac output on the x-axis, and you can see that once you put it on the y-axis, it starts to look a lot like what we recognize as the sort of Starling curves that we know now, and how they interact between, or the interaction between right atrial pressure and cardiac output. So just some interesting sort of analogies between Starling and Guyton that probably illustrated the same point, but using different mechanisms to prove this point. The easy way to think about the circulation is to use what's called the bathtub analogy. And essentially, like I said, most of your blood volume is in your venous circulation. So your arterial inflow fills up this bath. And essentially, what determines the return of blood back to the right atrium is the level of your right atrial pressure, or let's say the level of your CVP. So the lower your CVP, the more venous return you have, or the height of the bathtub. And the height of the bathtub is this interplay between your unstressed and your stressed volume. And your stressed volume is really what actively returns blood back to the right atrium. And that we can either increase by giving fluid or by transferring blood from the unstressed to the stressed volume. And the next part of my talk is really going to be about how that interplay occurs in different settings, but particularly in septic shock. I always say that CBP is useful, but it's not for volume status. It's more to tell us when there's a problem with the circulation, particularly when the CBP is elevated or rising. And we see that most commonly in patients who've had cardiac surgery. And when the CBP is elevating, we know there's a problem. In the old days, we used to chase the CBP to optimize volume status, or intravascular volume, but that was probably resulting in fluid overload. And what we realize now is that if we've got a rising central venous pressure, we've got failing physiology, essentially. We've got a failing right side, we've got fluid overload, we've got cardiac tamponade, but we have a problem. And a low CVP is probably a lot more reassuring than having a high CVP. The mean systemic filling pressure, or mean circulatory filling pressure, is something that we can measure. It's not important to know the value. I think it's more important to understand the physiology, and maybe measuring the right atrial pressure gives us some idea as to whether we're optimizing venous return or not. But this slide really illustrates very nicely what happens when we try and measure the mean systemic filling pressure by an inspiratory pause hold. Like you do a sort of a plateau pressure measurement when we're doing respiratory, measuring respiratory mechanics, you can see that the moment we use an inspiratory pause hold, we see the CVP starting to rise. The blood pressure drops because we're dropping cardiac output, essentially. You can see how the cardiac output drops. And it's essentially creating a equilibrium between your right atrial pressure and the pressure in your venous circulation, sort of in those capacitance vessels. And you can see that once your CBP starts to level off like that, it's indicative of this mean systemic filling pressure. And it's usually around 20 millimeters of mercury, but that's just, I think, in normal, healthy physiological beings, which none of our patients are, but it's just to illustrate the point. But I wouldn't recommend doing this in a shock state because you're going to cause the patient to crash hemodynamically. So it's really just an academic sort of exercise if you really want to measure this pressure. So coming back to particularly septic shock and using vasopressors and why we use vasopressors, well, we used to think that vasopressors increase vascular tone and that's why they increase your blood pressure, but they do a lot more than that. And this was a study looking at noradrenaline and how it increases your mean systemic filling pressure. And roughly, or broadly speaking, what noradrenaline does is it increases the transfer of blood from the unstressed to the stressed volume. And that's what the study showed. And it used passive leg raise to assess volume responsiveness. And what the experiment illustrated was that there was a greater change in your mean systemic filling pressure to right atrial sort of gradient with high doses of noradrenaline, much more so than low doses, which I think was quite an interesting decision, but in terms of the study design. But essentially, what noradrenaline resulted in was that there was an increase in your mean systemic filling pressure and therefore an increase in venous return. And it really comes back to why, particularly in sepsis, we started to see the change in recommendations with the new sepsis guidelines advocating early use of vasopressors. And particularly in patients with septic shock, where we see patients hypotensive, but often not volume responsive. And these patients are more likely to benefit from early vasopressors. And some of the data, although this was a very small study, showed good benefits. But what the studies overall showed was that the amount of fluid given to patients with septic shock was much less when we started vasopressors early, because we didn't chase their venous return with more and more fluid, particularly when their fluid responsiveness was not very significant. And noradrenaline almost achieves the same bang for your buck as giving patients fluid. And in this very underpowered study, the outcomes were much better when vasopressors were used early compared to late. So how early is early? Well, essentially, we want to start it at the time of presentation or once patients land in the ED, needing antibiotics, needing fluid resuscitation. So to start fluids and vasopressors almost simultaneously is really what's recommended, but particularly in the first 6 hours of their sepsis management. And you can see some of these studies looked at 2 hours, maybe sort of as a threshold for starting vasopressors. And the outcomes were favorable, although none of these studies were powered for mortality. Once we looked at the pooled analysis, it showed a signal for benefit in the early group. So just to summarize from this part of the lecture, early vasopressors were certainly associated with no harm and less fluid administration in patients with septic shock. There was a shorter time to achieve MAP targets, However, at this stage, I don't think there was a clear signal for any other benefits, but I do think that those studies were underpowered to show any differences in terms of other secondary or even primary outcomes in terms of mortality. I don't like to use the term aggressive because I don't think we do anything aggressive in ICU. I think aggressive management was now repeatedly shown to be harmful. You know, we don't aggressively ventilate, we don't aggressively feed, we don't aggressively fluid resuscitate. So we don't use noradrenaline aggressively, but particularly early is what I'm hoping to emphasize. Unfortunately, using vasopressors comes with its own set of problems, and I'm sure all of us have seen the toxicity associated with catecholamines, and there's almost a new term that has been born out of this concept of catecholamine toxicity, where you want to decatecholaminize your patient. I can't even say that, but that is a term that's starting to be thrown around because of the harmful effects of catecholamines. So this study paper, or this table, really just shows that, and we've all seen this with increasing doses of noradrenaline or adrenaline, we see worsening outcomes, and particularly when we get to these industrial doses of adrenaline, you know, we see almost 100% mortality. So there's this concept that's emerging, which is not new in terms of, you know, the sort of medical use of the term, but we've seen it in management of heart failure, management of hypertension, management of pain, this multimodal approach in terms of how to approach the management of patients with chronic pain or even acute pain, hypertension, heart failure. And there's no reason why we can't apply this concept to shock patients. And using noradrenaline plus adrenaline plus dobutamine makes no pharmacological sense because it's not a multimodal approach. In fact, it's just using 3 catecholamines targeting the same receptor and competing for one another, and no sort of synergistic effect seen between those 3 drugs. And unfortunately, it happens, but it makes no sense. And what we need to do is we need to look at the physiology behind our response to shock, and in terms of the circulation, what other receptors there are that we can target to optimize hemodynamics. And this multimodal approach you'll hear more and more about, and I think there is even some work looking at which patients are going to benefit from sort of optimizing their vasopressor management using multimodal approaches. But one of the more sort of attractive and more, let's say, we'll see it in the near future being more applicable and data to support its use, is to measure renin levels, because renin is a circulating peptide that can be measured, and it's almost as useful as lactate in terms of predicting, you know, which patients are needing, let's say, hemodynamic or needing optimization, and might be even able to benefit from using drugs like angiotensin 2, etc., which I don't think is available easily in South Africa, but it's certainly something that's been utilized and trialed in the developed world. So we will start to see this phenotyping of shock, and I don't want to spend too much time on this part because this is more related to cardiac surgical or patients with heart failure, but there are certainly phenotypes in shock that we don't recognize it at the bedside, but when one looks at different presentations, particularly in heart failure, we see outcomes are quite different. I don't want to talk too much about vasoplegic shock. It's a term we use all the time, and we see it in sepsis, and there's quite a lot of pathophysiology that one can go through when it comes to vasoplegic shock, and it might still be relevant in the trauma patient or the septic patient, and also understanding the different mediators that are at play in terms of the cause of their vasoplegic shock. And this is really where using multimodal approach becomes quite important. And I'm sure we've all talked about it and thought about it, but there's a lot of data now supporting the use of alternative or non-catecholamine agents like vasopressin, which I'd like to touch on, even methylene blue, angiotensin 2, hydroxycobalamin, ascorbic acid, and then hydrocortisone as a permissive effect. But to think about these alternative agents, particularly sort of once we've maxed out on catecholamines. Some interesting data on methylene blue that I don't have time to get into, but also lots of controversy around the use of methylene blue. So I'm not advocating the use of methylene blue liberally, especially in patients who respond to maybe sort of first line and possibly second line agents. It's usually a rescue therapy that might have benefit in some subpopulations of septic shock. I think one drug that I'm sure all of us see used quite often, particularly intraoperatively, and then it gets continued in the postoperative period, is phenylephrine. This drug has never ever been trialed in septic shock in large randomized controlled trials because it's certainly not a catecholamine. It's a synthetic alpha agonist, and I think we often see negative effects as a result of the use of phenylephrine, particularly in high doses for prolonged periods in an unmonitored type of environment. But this paper clearly sort of illustrates how the use of phenylephrine for hypotension can increase your risks of acute kidney injury. And it's probably because it's a pure vasoconstrictor, and it works solely on the alpha receptor, and it might decrease cardiac output, and I would not recommend using this drug, particularly in the management of septic shock. So what about vasopressin, this sort of peptide that we tend to think about only as antidiuretic hormone? Well, it's a potent vasopressor. It works on the V1A vascular smooth muscle receptor. Remember, there are V2 receptors in the kidney, and then the V1B are more central and neuroendocrine effects that are mediated by the V1B receptor. So it's essentially a dose-dependent effect, and we targeting the V1A vascular smooth muscle receptor. And fortunately, we've managed to get access to vasopressin. It is a Section 21 drug, and we've started using it. And the question is, well, how much evidence is there in support of the use of vasopressin? And I think the two studies that stand out where vasopressin was trialed in septic shock is the VAS study and the Vanish study, and they looked at different things. And unfortunately, these studies didn't show any outcome benefit. However, they weren't powered for mortality difference, but these studies did show some interesting results in terms of the timing and the use of vasopressin. The VOS study was the original study, or the first study looking at vasopressin versus noradrenaline. And what this study showed, the 28-day mortality was unchanged in both groups. 90-day mortality was also very similar. But when they looked at patients with less severe septic shock, there was certainly a signal for benefit in the vasopressin group. And I'll come back to that. The Vanish study looked at whether using vasopressin is harmful to renal function. And what the Vanish study confirmed was that, in actual fact, there was no decline in urine output in patients who were on vasopressin, and no elevation or worse creatinine clearance in patients who were administered vasopressin. And then there was a very nice sort of graphic to illustrate how we should think about when to use vasopressin. And certainly, as I've mentioned, with vasopressors, we want to use it early in the course of septic shock, but particularly after about a threshold of about 4 hours, if we're not seeing resolution or our noradrenaline dose starting to plateau, we're going to be obviously using adrenaline. But this was really just to illustrate when to think about using vasopressin, but also when we don't need to escalate to a second-line vasopressor, particularly when you've got control shock, patients are fluid resuscitated, and their noradrenaline dose is remaining static or even coming down. The timing of vasopressin has been looked at in sort of a massive American database. And really, once again, it showed that early use of vasopressin, particularly when the dose of noradrenaline is still quite low, and by low, it's less than 0.5 mics per kg per minute, shows significant benefit. And often we think about a second-line agent as a rescue salvage therapy, and then it's too late because we've missed the boat once the adrenaline dose is at 1 mic per kg and the digits are blue and the lactate is 20. That's certainly not going to be the time to reach for a second-line drug. We need to think about it earlier, and particularly when patients are showing signs of worsening septic shock. I think this slide I really just put in to illustrate that there's obviously a big push to using alternatives to noradrenaline, and maybe not alternatives, but when to use and introduce a second-line agent. And this review paper really just recommended that one wouldn't wean the vasopressin first. It seems like vasopressin, because it's a part of the pathophysiology of septic shock is vasopressin, relative vasopressin deficiency, is that we can continue the vasopressin even after weaning the noradrenaline. So that's certainly something to think about. There's still a lot of, I think, data that we need to see being accumulated to support the outcome benefit of using second-line vasopressors, and I think that hasn't been shown yet, but it's certainly an important consideration, and I think something that is going to change the hemodynamic resuscitation of patients with septic shock. We know that the outcomes of septic shock is certainly going to be primarily determined by early antibiotics, source control, getting on with treating the sepsis, and vasopressors are merely sort of supportive therapy for managing the patient's hemodynamics. This was just the data for angiotensin 2, and once again it was a very small sample size, but definitely showed that there was greater attainment of hemodynamic targets, and in the post hoc analysis there was even a signal for benefit. Remember that shock is complex. It's often, not as easy as do we give fluids or vasopressors. There's a lot more to think about, and we need to appreciate that shock is not simple to treat, and we need to obviously understand the type of shock and the underlying mechanism, and really to understand that worsening septic shock results in tissue hypoxia, acidosis, hyperlactatemia, and all those factors influence the outcome and influence the management as things progress. So shock can be quite challenging to manage. So coming back to the patient that I illustrated in the beginning of the talk, what we did for this patient was we needed more information. So we put in a cardiac output monitor, and nowadays we don't need to resort to major invasive sort of type of monitoring. We use pulse contour analysis monitors, which can give us quite reproducible sort of information. And it's really just to assess patients' fluid responsiveness and also to assess their vascular tone. If you don't have a cardiac output monitor, don't despair. We still can look at the arterial waveform on the monitor and looking at the values. And we often focus a lot on the systolic pressure, but we need to look more at the diastolic pressure, because your diastolic pressure is certainly what tells you a lot more about your arterial tone and your degree of vasoplegia. And there's even some recommendations to start vasopressors purely based on a diastolic pressure. So to look at those pressures more critically, and I think this sort of special issue highlighted that there's a concept called the diastolic shock index, which can be used to guide you as to when to initiate vasopressors, a bit like the systolic shock index that we used to use to determine what the degree of hypervolemic shock was. I'm going to leave you with this sort of 10 tips to optimize vasopressor use in critically ill patients, and it's really to look at risk benefit and to try and optimize the circulation. Obviously, we don't want to be using vasopressors when we've got severe hypovolemia. But we definitely want to ensure that we don't tolerate prolonged periods of hypotension. And even in patients who are bled out, who have a low blood pressure, the use of vasopressors should be indicated while we're resuscitating these patients with fluids, to ensure that we don't promote or don't tolerate prolonged hypotension. So set goals for mean arterial pressure or diastolic pressure, particularly when you're dealing with septic shock. We need to obviously always think about the individual patient, whether they're hypertensive, they've got chronic kidney disease, diabetics, etc. Remember that these vasopressors induce some form of fluid recruitment, and it certainly limits the need for aggressive fluid resuscitation, particularly in septic shock, and restores the blood pressure a lot quicker and a lot more effectively. We don't want you to forget about assessing the fluid status of the patients, and this might need to be reevaluated over time, particularly within the first 24 hours of resuscitating septic shock. What I would like to sort of plant the seed in your minds is to consider a second agent, particularly in those difficult patients. but then I think you need to have more monitoring, and you probably want to know what the SVR is, and you want to know what the cardiac output is. We never want to forget about hydrocortisone, particularly in septic shock. And then I think the important thing is that there's no maximal dose of vasopressors. We know that each patient has a dose response curve that is different. And remember, things like acidosis, hypoxemia, those physiological derangements certainly affect your dose response curve. And that might be the major reason why your patient's on 1 mic per kg of adrenaline, is because they're acidotic and the receptors are not responsive. We can talk about how to initiate enteral nutrition in patients on vasopressors, but it's not a contraindication, particularly if we've stabilized them and their septic shock is under control and we're starting to see their vasopressor requirements start to decrease. It's often an appropriate time to introduce enteral nutrition. And then we've seen lots of data now to show, particularly in the ED, that vasopressors can be used through a peripheral line, particularly in that early phase of shock, where you don't really want to be messing around with trying to put in a central line in a very unstable patient. So don't be reluctant to use it peripherally. And I think, you know, those sort of myths that vasopressors cause renal failure and renal vasoconstriction, that's not entirely true, because there's enough data to show that restoring the blood pressure is probably more important to promote perfusion to your vital organs than it is to cause sort of worsening tissue ischemia or particularly renal ischemia. And I think the Vanish study showed that.